Say something.
Yeah, we'll see how long I get to stay.
Would you like me to? Is that what you're saying? Yeah.
That are different.
Yes.
Include communication.
I'm coming.
National meetings, they're talking about public government.
Oh.
Yeah.
No.
There you go.
They're doing.
All right. So you say
All right, everybody, you're muted. Morning, we'll go ahead and get started. We'll start with roll call. All right, Lindsay Weaver here, and Dr. Yeazel. Okay, and Dr. Zaire.
Good morning, I'm here.
Perfect, thank you. Dr. Stride,
Tribe is here.
Andy Van Zee,
Present.
Dr. Weinstein. Dave Blanton. Here. Dr. Fitz. Here. Mr. Hollister. Here. Dr. Landman.
Present.
Dr. Welsh.
Present.
Thomas.
Present.
Dr. Woodland.
Present.
Have it quorum. Please be advised that this is a public meeting in accordance with open door law that is being live streamed to the public and recorded. The recording will be archived and available to the public for no less than 90 days. By attending and participating in this meeting, you acknowledge and consent to the live streaming and recording of the meeting, including your image, voice, and any contributions you make. PCC members, because you are invited as a presenter, you can unmute yourself and turn your camera on. For other virtual attendees, if you have a question or want to make a comment, you will need to either raise your hand or let us know via the Q&A, not the chat, and that we will open your line. You can then unmute yourself to participate. The recording will be published and cannot be edited. Thank you very much. All right, we will start with an update. Morning, everybody. A lot of things have been going on here at the Department of Health. You're going to talk about rural health transformation, correct? Big focus on rural health transformation. I just again want to thank all of you. I think that this has been years in the making, and now that we have funding available to help support the movement of this work, we are taking advantage of this opportunity, and I think Indiana will look different when the funding ends 5 years from now. So thank you for your participation now into the future. I'm excited to hear about the progress occurring in the regions later today, and I think you guys can see all the agenda items here. Any questions for me? Shoot, I did miss it. Yeah, thank you. I normally do it with, I'm reminded we did not approve the minutes. I normally do that when you guys do your first roll call, but now I do have to roll call you again. So really quickly, first of all, any comments or corrections to our last minutes from February 6th? Hearing none, move to approve.
Second.
Okay. All right, I approve. Dr. Yeazel.
Approve.
Dr. Zaire.
Approve.
Dr. Stride.
Approve.
Benzie. Lee Blanton. Fitz. Mr. Hollister. Dr. Landman.
Approve.
Dr. Welsh.
Approved.
Dr. Thomas.
Approve.
Dr. Woodland. Excellent. Ryan, on to you.
Thanks, Dr. Weaver.
Hi, good morning, everyone. So happy to give an update on Rural Health Transformation Program. As a reminder on the list of initiatives, so This list is actually short by one. There are 12 initiatives, the 12th being the regional that are actively available to everyone, and teams I know are working with different regions to put together strong proposals there. But the two initiatives that I want to give a more detailed update on are actually number 1 and number 4. So the Medical Operations Coordination Center and then the Pediatric and Obstetric Readiness and Rural Emergency Departments. So by way of an update for Initiative 1, we have continued to have an executive level steering committee meet. So they have been meeting for the last couple months. A lot of the focus for those meetings has been sharing from other states. So we were able to bring on some folks from the state of Oregon and give a nice presentation on what they've been able to do in Oregon, lessons learned for their coordination center. And then we also were able to have Southwest Texas join and give great presentations to the group. More recently, we've been provided some information from Dr. Strive, who has recently met with the state of Alabama. We're looking to bring them on to present some of their history and lessons learned from their approach. I was actually really pleased to see some of the background from their story. It seems like a very similar path that they have taken in their state that we are going down, at least initially. So looking forward to bringing that group back together sometime in May here to give Alabama's presentation. The real meat of the update, though, is our request for proposal. So many of you are likely aware that we are following state practices to solicit services from a vendor to stand up the mock. Specifically, that RFP will have 2 components to it. So it'll have a services component, think the operations behind making decisions, helping assist with the coordination of care, initially with interfacility transfers and behavioral health triage, but we know that we can become much more mature as we move into the next 5 years and build those 2 initial phases. The other part of that RFP will be a system. So think the technology behind the healthcare system across the state. So we want to know capacity across the state, and we also want to be able to inform patient flow across the state. And so this RFP is intended to be released in mid-May. But that is the slight shift that we took. Initially, we were only going to stand up a vendor to operate the operations of the mock, so the decision making. But we determined that it's the best interest to merge those together and give those entities across the state and even external to the state an opportunity to partner and come forward with the best possible solution through the RFP process. So excited that that's moving forward. We're moving fast and furious to make that happen. On your right, you'll see a couple of, just so we are talking timelines. We know it's a 5-year award for RHTP. This first year is outlined here. These are the key priorities and activities that we're going to be focusing on. So it's obviously getting the vendor on board, ensuring that they're hiring the appropriate staff, establishing an advisory committee. That advisory committee is going to be crucial to the ongoing decision-making, procedural processes, guidelines that are going to be formed for the mock to operate. Many different examples of an advisory committee exist, I think, across the country, but I think initial intent is that trauma centers will be involved. Obviously, EMS leaders will be involved as we make up that advisory committee with the support of the selected vendor. Obviously, implementation of the healthcare emergency and hospital capacity system. Also identifying pilot areas. So we want to take a pilot approach with this first go at it. And so there will be pilot areas across the state. 1 in each region is what our initial plan for that is. And the advisory committee will be key in identifying where those areas are. Obviously, operationalizing and utilization of the capacity system, and then implementation in those pilot areas, all by 7/31/2027. So that is our goal. Again, we are trying to be aggressive with this, but do know we have the ability to pivot if we need to and slow down if we need to. But that is where we sit with Initiative 1 and the mock planning. For Initiative 4, so pediatric and OB readiness, this outlines kind of where the plan is at current state. So we are finalizing agreements with IEMSC and then the IU School of Medicine to support scopes of work for the pediatric and OB hospital activities. And then we're also working directly with the Department of Homeland Security for pre-hospital and EMS activities associated with this. So additionally, a scope of work. But the BP1 activities, I think, outline a little bit more about what those activities are going to entail. So certainly want to leverage the NPRP assessment for hospitals, but also developing an EMS assessment as it relates to pediatric and OB care / readiness across the state in our rural EDs. And then a big component of these agreements is going to be how are we actually supporting financially these institutions, these rural EDs, to support the things they need around staffing, training, supplies, and equipment. And that's where these scopes of work that are being developed with IMSC and the IU School of Medicine will really have a lot more content and detail around what that's going to entail. That's where we sit with those two initiatives. I want to stop and see if there's any questions as it relates to those. And then if there are any questions about any of the other initiatives, and answer those questions. Yeah, Dr. Thomas.
Brian, thanks for the update. I'm just curious, and I know Dr. Weinstein's not here, but what's the definition of being PEDS ready? Like, what's your target? Like, is it a pass-fail deal or number on it? How do you define it so that say, okay, you're PEDS ready now, we can move on?
It's a national standard.
Yeah, I
It's
just
like-
didn't know if it's a pass-fail thing.
Oh, it's like if you read so many of a score, like if you're 80% and above on your score, then you're considered pediatric ready. But it's a scale.
Yeah,
We would work with them until they got there. That's the goal, right? Yeah,
The goal's 100, but at least.
yeah.
Once a facility gets above the 80, how long is that good for? Do they have to recertify?
That is a great question that I am not sure about. Dr. Lehman?
I don't know either, but it's like a trauma center. Once you're verified, no one looks under the
Okay.
hood for another 3 years. So
3 years, okay,
things can
Yeah.
fall apart and,
Yeah.
you know, but it's.
The PED survey is done every 5 years for emergency.
Well, the other thing I was going to point out on that, and maybe the health department can assist, is my understanding is that the current survey response rate for Indiana and nationally is pretty poor. I think there's a month left. So if there's any nudging that can go on, I think we're under 50% response. Is the last I heard.
Correct. On the last slide, Margot sent me an update. I think we're at 40 out of like 100. So there's a push, and we're going to see it at the end of the day, but definitely push to get that in because we have till the end of May responses to be submitted.
But that's the key, right? We're gonna see where we are today, and then after we do this push, then you're gonna look at your numbers and hopefully.
Usually comes down to the couple days before we're literally told by the departments and things like that, yeah.
Well, I can add too, the tracks are helping get this word out too. So other tracks are sending out emails to other hospitals, working with Margot to make sure the folks that haven't applied or said anything are aware as well.
You send it out to ASAP.
Yep.
Emily, and then Andy, can you make sure everybody at IHA knows? Jay, if we're coming at them from different angles, maybe they'll get there. And then are you guys sending it out to all the medical directors? Okay.
So Weinstein is telling me she's trying to log on and
Tammy just sent her a link, I think so.
Working on it. Thank you. Hospital spinal immobilization.
Yeah, we wanted to address the commission today, just to talk about C-collar and long spine board mobilization. You know, the traditional approach has been just broad application. The risks of not can be devastating. And so, we've kind of done it to everybody and then had a selective approach as they work their way through the process of removing the collars, getting them off the boards and things like that. There's been a lot of research in this area, and over the last few years, it's kind of become a little more apparent that's not as benign of a process as thought. And there's a groundswell through some of the EMS organizations, emergency medicine organizations, and I believe the Committee on Trauma talked about it as well too, on a more selective approach to applying C-collar, long spine boards, and being more intentional about rapid removal and things like that as well. So Sandra Bowman from the EMS Commission has some research on that area as well. So.
Basically, we just wanted to present today information that hopefully as the Trauma Commission can be supportive of the EMS Commission's decision to maybe advise EMS responders that, don't really need to everybody on backboard pair of buttons.
Last few years, the National Association of Municipal League has been researching different aspects of pre-hospital trauma care, including last year, they published the Continuum on Pre-Hospital Management of Spinal Cord Injuries, review analysis of the literature, and basically they're finding that long backboards we got rid of quite a long time ago before being used, but now we're focusing on ability of people. Finding that secondary injury is more often than not due to inflammatory response, hypoperfusion, hypotension, and not due to indiscriminate movement, patient's head and neck. So just saying that we keep you on a cot, lay there, let us do our things, be as good or even better. Some of the things I did find is that E-collars are really ineffective in true spinal mobilization of the cervical spine. In fact, with high spine injuries, C1 to C4, they actually don't really prevent any motion, not be harmful to the patient. There are side effects or evidence of harm, pressure sores, respiratory compromise, increased intracranial pressure. Detriments leads to more radiographic intervention, so exposure to radiation that's not necessary. In penetrating trauma, there's increased mortality by placing these patients in a cervical column that have penetrating trauma to the head and neck and chest. And that there's better alternatives. So instead of indiscriminately putting everybody in a C-collar who suffered some kind of trauma, let that patient's symptoms guide the care. Self-extrication, soft collar immobilization, if thought required, and getting away from the rigid collar use and applying that to everybody. So we're just looking for your support as a trauma commission, evidence-based practice and information to help guide pre-hospital care in Indiana to reducing the use of C-collars indiscriminately.
Yeah, I think we've had some dialogue with some of our services that want to be early adopters of this literature. And, you know, we want to make sure that's not over applied. There still are some very appropriate candidates for C-collars. But also we know that this isn't something that needs to be done through EMS or emergency medicine unilaterally. I think this should be more of a group approach. And if we do, you know, what does that education look like, you know, across the board?
Have any states adopted this change in approach statewide?
Not at the state level that I know of. There's a lot of states that have state protocols and none of them have changed that in their state protocols that I'm aware of. There are some large systems in Florida that actually have removed C-collars altogether, which is a little more aggressive step than I would recommend, but they are seeing some radically decreased use in some of those systems.
Kind of going along with that, I think in the legal aspect of this, if you stop doing it, I would think some trial lawyers would likely go after folks for stopping you.
I think that's why we've been, yeah, that's why it's been a pretty broad application for that concern, I think, yeah.
Is the presumption here, this is a conversation about adult trauma, or is this across the spectrum? And I'm all for challenging the dogma. I would say that in this paper that you presented, not anything to prove its efficacy, and there's clearly lots of things against it, but this is hard. This is a hard negative to prove. Like, no one's doing that study where they just take these collars off in patients with cervical spine, concerns for cervical spine injuries, and saying what happens. So I'm a little suspect of the literature because you're trying to find that probably will never be studied. That's a long statement for a question. One, is this about peds, or are we excluding that population? And if we're not excluding them, I have reservations.
Yeah, my review of that study from MSP really did not focus on adult. And going back to the 50s and 60s, where literature said you have to take someone out of a car using winches and pulleys.
Right.
Clearly, that's not that goes through the patient. But also recognizing that there's really not been any large documentation of injury not applying a cervical collar. There is evidence of harm.
So does that mean if there's evidence that says it's potentially harm, you also are at risk of a lawsuit on the other side? Honestly, this is probably my favorite conversation we've ever had, but so keep talking. While I look up how much does a C-collar cost, does anybody know?
Around $50, like a soft, like a, not the extrication collar, but the actual,
And on EMS or free?
I don't know how much that was.
That's a big point here, I think, is the ones that EMS carry are, you've seen them all. They come into the ER with them, you know, up to their nose and things like that. They're not. And so I think if we use them more discriminately on the appropriate patients, we might be able to justify the better quality C-collars from a financial standpoint as well. when we're going to burn through them, 10 a day in an agency, that's hard to justify. If we're picking the 2 or 3 that really need it and getting the right equipment, that might be better served too.
And some places are even going to just the Eagle soft collar. They, people come to the courthouse, say, oh, I got whiplash, they get the soft collar. Some agencies are using just that for their pre-hospital or spinal motion restrictions, they like to say.
So spinal motion restriction came up at the Committee on Trauma and it was thoroughly vetted. I don't know where we are because I don't sit on that committee. And Dr. Stribe, I don't know if you've been involved with those discussions or not. I know Dr. Welsh, you also attend, but I don't sit on those committees. But I do remember the long board discussion that went on and on and on until we got rid of long boards for the most part, except for extrication. Made sense after it was all vetted. But there were 19 different groups that bought onto it. And then the national recommendation was pushed and we made a decision. This one we've looked at in the north, trying to identify as something that we should be agreeing with. And at this point, I'm going to probably tiptoe to Dr. Landman's point. There's a lot of other issues that I think we need to vet, look into, and then bring in other agencies. And it should be a collaborative effort from my perspective. So I'd like to see, I'd love to hear from our COT colleagues that sit on those groups and try to figure out, because there is very heated discussions that went on during the long board. And now it's getting into, and I agree with everything that's, been pointed out as far as some of the problems that
Just how to step forward.
pointed out. Yeah, and I think that
Dr. Hayes and I think,
we need to consider where we're going with it.
I think Dr. Hayes and I agree that we're introducing this. If you don't talk about it, nothing happens. But we have evidence that perhaps there is harm. There's evidence that perhaps there's not that much benefit. Let's take this step.
Curious what I just texted. We have Dr. Ben Rogers is on the COT committee for our surgery, whatever that group is. I just texted him to ask the recommendation was, so if he texts back. Tribe.
Yeah, I think this is something that, it's a multidisciplinary issue between pre-hospital providers, emergency department, hospital providers, and then specialists that manage these injuries. And I think that this review article points out that there's a lack of evidence supporting the use of the widespread use of C-collars, but a lack of evidence doesn't mean that they're not ever necessary. And so I would say that there are things like the ACS TQIP best practice guidelines on spine injuries does have a section on pre-hospital treatment, which says that you should have appropriate indications for spinal immobilization. When you do, you should immobilize the entire spine until the patient's been evaluated. And if there are, criteria to remove immobilization, that should be done by adequately trained personnel. And I think in the pre-hospital setting, you've got a variety of different training levels. That there needs to be some uniform education and training. And to me, that would be, PHTLS and ATLS, both of which are products of the American College of Surgeons. But those are widely recognized training programs that are in alignment with these other best practice guidelines. And I think those groups are open to the best evidence-based practice, but I would recommend against deviating from those sort of accepted educational and training programs, because that's how we're training our providers. I think that would create confusion. So that would be my recommendation, is that we should follow the current edition of PHTLS, which is developed between trauma providers, neurosurgical specialists, orthopedic people, and pre-hospital associations. Follow those guidelines when we recommend education and training for spinal immobilization.
So, and this group is well aware that the college has just come out with the latest edition of ATLS, the 11th edition, is just getting rolled out into the teaching of the ATLS courses. It still includes the use of the C-collar. Now, just like on the backboards have evolved, this has evolved, like everybody in this room knows. Don't have to go through the steps you used to have to go through to clear somebody. You always thinking about mechanisms, they awake alert, can they respond? So you don't have to do that massive amount of x-rays we used to do. So I ditto the other comments that it's an evolving thing, but the current use is still included in the latest edition of ATLS.
Hopefully C-collars kind of go through that same progression, right? We did away with the ambulatory MVA that we did the standing takedown and put them on a board. And same thing now where, you know, we're just putting them on everybody regardless, you know, starting to move to a more selective approach and then, you know, see what the data says. And hopefully it'll be interesting. Some of these, I'm not kidding. There's some large counties in Florida that they don't carry C-collars anymore, which seems, that's a little bit aggressive to me, but I think they're planning to research that. So maybe we will get some data on it, but it'll be interesting to see because again, there are some that, you know, that need those mechanism, you know, intoxication, some things like that, you know.
Things do change. When I started my training many years ago, they were just ending that week of bed rest after inguinal hernia repair. So things can change for the better.
Things can change, but we are really slow as a practice to pick up on new things. So I really appreciate you having these conversations here. I would appreciate for you guys taking this back as the surgeons, and I think also from the ED side, to think about and like start looking at the research that if we were to start moving in or making any changes, what would that look like? I will say in my own personal practice, if you have a gunshot wound in your foot, you're getting a C-collar these days. That might be a little bit of exaggerated, but I think that we have room and opportunity here. And I also agree with Dr. Stribe and others that we should move together, right? I think as a state, that's why we have these state meetings like this so that nobody feels like a need to kind of go out on an island. And they are not cheap. So there is actually, you know, an opportunity. They're anywhere from $20 to $100, so probably $50 range. And I can only imagine how many of them are wasted across the state today. So we should be having these conversations, and I appreciate you guys taking it back, and we'll continue to talk about it. Thank you guys.
Thank you.
Appreciate it. Sweet. Any other comments on that? Okay, moving on to the track. I think we're starting up north, it looks like.
All right, for the North, first I'd like to thank Nicole Raylander for putting these slides together. Does a great job for these excellent for our region. Yes. Any question?
Good work.
She did a great job on the slides for you.
That's very efficient.
Could have done those.
I guess I have to wing it. Slides aren't up. So let's see if I can go by memory. I don't know who put them up, but I think the most important thing I need to point out is that Lisa Hollister is retiring. This is an extraordinary, close to an extraordinary year for the North in specific, but for the state. And the loss of Lisa is going to be very impactful in a negative way for us. We want to figure a way of how we can replace her as vice chair of the North Track, and that's what we're trying to do right now. That's a big part. But for those of you who don't know, just historically, the history, if you go back 25 years in Indiana, there were only 2 trauma centers in the state, and that was Old Wishart, which is now Eskenazi Methodist. And the first trauma center to be verified outside of Indianapolis, Parkview. Correct? The result of that was from the hard work of Lisa Hollister and your medical director, Dr. Allenden. It was a monumental leap. That really started the discussions. And when we started volunteer groups to come down to Indianapolis and figure out how we were going to initiate a trauma system, the state. Now we're looking at Parkview becoming the first level 1 trauma center outside of Indianapolis, hopefully in December this year, which is very exciting. And the most important thing is to recognize the people that make that happen. And the people that affect the lives of the citizens of Indiana, directly and indirectly. And I just want to say that from my perspective, there's nobody who's been out there as aggressive as. We're gonna miss you. I know Dr. Lee.
Miss everybody. To that end. I think is in here. Lisa.
Heavy.
Present you with the State Health Commissioner Award. Oh my gosh. In contributions in preventing injuries, saving lives, and improving the care and outcomes of trauma patients in Indiana for over 30 years.
Other than this has been amazing, the time has went so fast. It's unbelievable. 34 years. It's been a great system to work. I don't know about the word aggressive, but that way sometimes, but I've appreciated all of it and working in this awesome system. Thank you so much. I did not expect this.
Yeah, we'll take pictures. We'll get all of us together, and take a picture. Yeah.
All right, Dr. Thomas,
Yeah, you
we had to do a little bit of a pivot, but you have slides.
I'll quickly run through this. So we were able to purchase 3 trauma mannequins for all districts north, which was fantastic, high fidelity mannequins. Now we can have great classes with the best kind of training tools that are available out there. We have sent a survey out to all the hospitals in our area to see how our registry reimbursement funds were utilized. Accountability is important. We want to make sure that we're utilizing the funds appropriately. So we're going to find out before the next cycle runs, and it's coming up soon. So we'll be getting information back from the other hospital. Save the date will be coming out for everybody for the Great Lakes Regional Trauma Symposium. It's here too. I want to thank Jen Holman, Trauma Program Manager up at Crown Point. She's done an amazing job with her team to bring in great speakers. We have another list of great speakers coming in. So watch for that, and that'll be in the city. We did have a RIC event. Dr. Pullman and his team came up to Bremen, which well received. If you know Dr. Pullman, retired trauma surgeon from Methodist, another passionate trauma care for our people in Indiana, and especially in that rural environment. Job. We were very happy to have him. We did start a PI subcommittee that just had an initial kickoff meeting. We're looking at pushing a PI awareness campaign, and then most importantly, looking at the gaps that we need to identify in the north. Everybody has their own district issues and region issues. We have our own, and we want to find out in line with the state PI initiatives. So it's all same kind of realm. We are looking at engaging for this year and hope that we can put together a regional disaster program. Possibly, we're going to have a third party that possibly can put this together for all of our districts and make this happen. I hope it can happen. Not sure. And then the other thing we're doing is we are working with a third party vendor. This thing, can you advance it? Called TechServe, who's worked with the state, with IDOH before. You guys know their reputation. We're going to use them in the north to develop our website to help us with a public facing website and access portal for members. Then put together some stories, some impact stories and testimonials. You can go to the next slide. Oh yeah, here we go. So our last meeting in April, about 50% of the hospitals attended the track meeting, all the trauma centers. We had 2 out of 3 HCC representatives there. We've got EMS and rehabilitation representation, and our budget is almost spent down. This says 115,000. I think we're in the 30,000 range right now from a couple of other things that we're going to spend, and hopefully by June 1st, we're going to be zero balance for the next funding cycle. That's my report. Yes, Dr. Weaver.
I think to me, 50% of hospitals being represented sounds really good. I mean, is that, or has it been growing, or is it kind of waving or?
The last couple of meetings, it's about the same. So we really need to promulgate that more and get that involvement.
Is it independent hospitals? Is it system hospitals? Who are you struggling to get at the table?
Small independent hospital.
Independent hospitals, okay.
A good question because we want that inclusivity.
Like, let us know how we can help, maybe getting them to the table. I'm also even thinking through the RHTP, if that can't be kind of part of a way to get people to.
Sure.
Okay. Thank you.
Try.
Question perhaps for the group, is this website development something that would be to do for 3 tracks as a bundle or this as a pilot?
Yeah, so that's the conversation I was just having with Vince, understanding that if we've worked with that company in the past, for purposes of uniformity and alignment, it might make the most sense to support it from a statewide perspective, just so we do have that alignment. So we can take that back, and we don't want to slow anybody down. But knowing that you guys have a potential opportunity there, we'll coordinate with you guys and all the tracks.
We're also attempting to plan a whole North live MCI drone.
I want to come.
That's our goal. You get that done this year, that.
Yes.
It seems to go.
All right, Caitlin, I will. Stacey,
But it is for,
It's our
it
central
is
track.
central track.
yes,
That's taken.
all you.
If you don't know me, my name is Tracy Spitzer. I'm the trauma program manager at Riley, and I'll be stepping into Caitlin's spot as the chair for the central track. They're going to present our strategic plan and our update. So for the previous year, we did see some increased participation for our central track. We had a lot of, I think, as the year has gone on, increased collaboration across districts. We saw a lot of sharing of best practices. And so we really feel that it has improved across the last. Again, increased participation from our advisory committee members in developing our 27 plan. We've seen increased participation from both EMS and other hospitals. We did I think, a really good job of spending down our budget, as you'll see on the slides, for the 2026 year, and reviewing what we spent, what was needed for this coming out year, and to better plan our strategy. Some funding impact highlights integrated into our quarterly track meetings. So we've had people who have received funds come back and kind of talk about what they've used it for, what their outcomes have been, they plan to do in the future. And then strengthening our review process of data quality reports for our C-track and coming up with some more PI needs from a central track. Some of the funded initiatives that I've included is we've done a lot of pre-hospital blood programs, especially in Area 2. Area 4 has participated in and is doing EMS cadaver labs and has been opened up pretty much across the central track. Training equipment, symposium support in most of our major hospitals. And some of the other ones, a lot of stop the bleed kit requests, barrier buster for HVIP programs, and car seat resources. And then for Area 6, MCI equipment, RSC funding. Things we've done. In terms of central track meeting participation, we saw about 30% of our non-trauma hospitals participating, so still definitely something that we're working on. And then 85% of our trauma hospitals participating. Again, we had various EMS and fire departments that have participated throughout the region, and that continues to be a strong representation from them. HDC representation and behavioral health, had rehab hospitals. From a budget spent down, our initial budget was 65,000, just a little bit over that. We did from an additional funding, 61,000. We allocated over 876,000 with the amount remaining at up to over 50,000. Questions?
Would you also some help in trying to maybe incentivize these hospitals to come?
So we have done some incentivizing for our non-trauma hospitals to try to get them. And so again, we're looking at kind of the data and what that has done in terms of getting them to participate.
Who is coming from these smaller hospitals?
I'd have to look, Caitlin, you know.
I mean, like not the hospitals, but is it like is it the nursing director for the ED? Is it the general surgeon for the hospital?
I feel like it's
Medical-
mostly the ED.
The
I'd
ED.
say those, yeah.
That just helps me to think who we should be communicating to. Perfect.
I think one thing to think, most of these are system hospitals. There's
They're the
24.
small system hospitals.
only 20 true independent hospitals left in the state. About is, I think that's part of why they don't come, is the system hospital comes. So
Because I wondered that on Parkview. Is all of Parkview counted in North Track? But I was there.
But are you taking it back
We
and
run it as a
communicating
system.
to those? You're thinking of it as a system.
Our trauma program runs as a system program. So it's a system department that oversees all of the registry and all the outreach and all the prevention. It's, so even like, let's say, I don't know, any of those, we collect the data. So we're interacting with the ER and all of their committees. So yeah, it's a unique setup.
Do we know if the other systems are functioning that way?
No, most likely not. It was, you were like, yes, you're part of IU, but it was very much, ours is unique in that way. It's a system.
Yeah, we're similar to you though, that Beacon Health System, we're a system now. So our representation is system representation
See, like,
for all hospitals.
we even have a trauma program manager for all of the community hospitals that's within the system. Does that make sense? Where I think you're going in that direction. It's a very unique setup. It was when Parkview started.
Yours is
You know,
ideal because you truly do communicate with all of your other hospitals. You have them tied in, but to Andy's point, that's not the case for a lot of
Yeah, I think it's
systems.
but yeah, just I think the way it was presented, like these were independent, like small hospitals, they're independent, or sorry, there's small system hospitals. And that's probably the reason why they don't think they need to come, is because the system's there, or the larger hospitals there.
I would say too, just from visiting a lot of these and being on site personally, I don't know how much of that they get an opportunity to be there, like comes back, all the nuances too. And I wouldn't say Parkview is, I think, a little different in how they're structured, but a lot of them, I don't think they even know if someone from their system is
They're
there.
just not communicating.
Yeah, they just don't think it, right, for a multitude of reasons, and that could be one of them. I'm not saying it's not, but just from my own personal experience and talking with folks in the EDs that are at critical access or smaller rural centers, it's very much what Dr. Fitz said. They may be part of a bigger system, but they still don't hear that, right? So they don't get it. So we do encourage a representative from every hospital so they can help take that back or take what's more salient to that hospital. There's different things that come out of these that, bigger trauma center might not care as much about some of this stuff because they've got a very strong plan, where some of the smaller hospitals may be able to pull away different information and incorporate it for their needs. So
I think getting them there individually for the buy-in is important, right? If you're not going to the meeting, you've got less buy-in to it. You're assuming you're going to hear the important things, but part of the system, yes. But I think as you can for staffing and other reasons, it's still very important to get somebody from each facility to show up because you're going to get a lot more buy-in from it. And better discussions.
But I think that sounds like there's an opportunity to discuss this with the systems, that they need to support engagement.
see, even in our system, we have ER management that's combined. So several hospitals have the same ER manager, so there's a lot of administration and a lot of, I don't know if that's that way everywhere, but we have a lot of fencing.
You?
Morning, everyone. So first, want to thank the other tracks. I learned so much about all you're doing, and can we do that in the southern part of the state? So lots of good things. I liked your website thing. I want to really make sure the folks at IDOH know what a great job Kim is doing, keeping us on track. She is awesome. And also big thanks to the Evansville area, both the hospitals and EMS. They're kind of like lead on a lot of projects in the Southern Track. So a lot of the same things that the other speakers have mentioned. We've got a lot of potatoes stuff from the track initiatives, getting warmers for blankets, for getting working with pre-hospital transfusion products, getting people to training, education. We actually have a cadaver lab coming up this next weekend at Harrison County. So I get to work with Dr. Yazil firsthand. And it's going to be a lot of fun. Everything from stop the bleed kits to car seats. Interesting thing we found out with the car seats is you have to be certified to be able to put it in. So some of the places that were asking for it didn't have the certified folks. So one of my suggestions to him was to work with the local health departments who do have more certified car seat instructors. We're also working on getting feedback from people who've gotten funds and see how was it used. And then, so bicycle helmets, also a lot of folks have had injury reduction programs, fairs. We contributed that. Bloomington was one. We had several. And then the other thing that's really, really encouraging is when this started, it was mostly around the Evansville area. Now we're getting asked from across the Southern Track. So the word's gotten out, people are responding. One of the, I know, is the slide about the percentage of the numbers in here?
We're a foot higher now, but that's
Okay.
a good ballpark range for like
But the-
differences. So like total non-verified hospitals, 202 individuals have had courses reimbursed. From your verified trauma centers is 173, and pre-hospital courses 160.
And Dr. Yaz will be happy to know that we're closely with EMS across the Southern Track, getting ideas. And then earlier this week, we had we're doing the spend down like others, and we've had some increase in availability, which we really appreciate. It's helped us to get more done. One of the areas that we're having, our highest amount is on quality improvement. One of the areas that we're having scratching head on, and maybe the other tracks can give us some suggestions. One of the items that we were looking at was Southern Track sustainability. And while we do really well with education and injury prevention and quality, that's one area that we're still scratching our heads, like looking for ideas and projects, how to get the Southern Track, the whole process more sustainable. But earlier this week, I don't know if it's on.
All we have, Dr.
Okay.
Welsh.
So earlier this week, when we had our meeting, one of the things that was really neat to see was the number of requests were initially approved. The number, so we had 62 requests, 41 approved, 13 were denied. It wasn't kind of in our wheelhouse. And 8 are pending. So in some cases, we're like, yeah, you're kind of, it's a good idea, but it's not, you haven't really all the kinks yet. So we have sent it back to like, should massage this a little bit more. And the response has been very, very good, very forthcoming. So I think the thing that's most gratifying is we're getting more smaller hospitals, more non-Evansville area hospitals and EMS to reach out. The other thing that this has helped, getting back to what was mentioned earlier with the rural health transformation, some of the things that we discussed that the Southern Track may have spilled over to the discussions in the District 6 with the rural health, because some of the things that Southern Track is doing, we put in for as an initiative with the other things. So we're hoping that we can get more done working from different areas. And I'm also hopeful that at the Public Health Day, the governor mentioned to the crowd that there's going to be more resources for Health First Indiana. Some of these projects can also be supplemented when the Health First Indiana funding is increased. Fingers crossed. Are there any questions?
Is there anything else you'd like to highlight?
I ran some general numbers. Wednesday was a really busy day, but we did have our track meeting. I think it went really well. we were competing with the District HCC conference that same day. And then Region 6 met for live in person to go over transformation funding. So we had 15 out of 25 hospitals represented, strong EMS representation, some HCCs, but obviously they're having their conference in one. And what I'm really proud of in the South is really how inclusive we are. The projects that we've had are having a regional benefit. Look at the cadaver lab. Everybody was offered in the region like us to participate. We have the pre-hospital blanket warmers. The high fidelity simulator is going to be delivered in May. So once we have 20 super users that are going to go through that initial training, and then we're going to start targeting those non-trauma centers and getting hands-on. So just really inclusive, thoughtful, really proud of my leadership and advisory committee and things like that.
He's awesome. Please don't take her away from us. Thanks.
Yes. Year two strategic plans as presented with the funding allocation as outlined.
Those are all in your packet of papers here. Are there any questions or comments about that? Is there a second? There's a second, so we'll do a roll call vote. All right, I move to approve. Hazel.
Approve.
Dr. Zaire.
Approve.
Dr. Strub.
Approve.
Andy Banzi.
Approved.
Dr. Weinstein.
Approve.
Kelly Blanton. Approved. Dr. Fitz. Approved. Lisa Hollister. Approved. Dr. Landman.
Approve.
Dr. Welsh.
Approved.
Dr. Thomas.
Approve.
Dr. Woodland. All right, so the strategic plans and funding allocations are approved for 2027. Great job, everybody. All right, moving on to the EMS update. Cool.
Catch up with you, Dr. Hazel.
Here with me today, Director Kinney, all of us actually were out in Kansas City for nationwide conference on EMS officials. Director Kinney's the incoming president, so cool thing there. And then we also won the State Innovation Award for nationwide. So good things going on. He had some travel snafus, mainly education and workforce and things like that with the category. So yeah, good things going on. He had some travel snafus. He had to stay a little longer than I did, so you're stuck with me.
You have to use the keyboard, Dr. Hazel.
We can do it for you.
I think a lot of his initial slide, you already went through the GROW initiative, so I don't think we need to touch on those again. We recently put out our 2025 annual report. It is available online. A lot of good study, like educational things, workforce studies, our numbers, how many services we have, how many runs, all those things. So anytime you need that data for your daily operations, it's available in that annual report. And the other ones are indexed so you can compare to years past and things. So I think a lot of the first slides were like things we're doing out in the state, which is probably not relevant to this. So we may.
See if you can do anything up there.
Right, the little thing.
There we go.
Oh, yeah. So,
Oh, that's all going to
yeah,
be. You or me, does it?
it's not me. I go. All right. Where you want to be?
Yeah, say a lot of this is like our EMS commission, some of our participatory things, some of the meetings we went to, not overly relevant. I do think it's important. We did do some statewide support for mental health education. We're continuing to grow those platforms. I think, as we talk about workforce, taking care of the workforce that we do have needs to be one of the biggest priorities. And we are recognizing, the day in, day out stress and things like that, and making sure that our responders have a strong support system. It's been a little bit of a challenge because some areas do this extremely well, and then some areas have very little infrastructure. So figuring out how to help some that don't without stepping on some local toes is a little bit of a challenge, but we're continuing to grow that and put that together. We do have our EMS readiness funding, which is an offshoot of the HFI funding that we mentioned. We did a lot of AED grants with that, some test prep packages, which basically, if you finish your EMT or paramedic course, we'll put you in one of those classes that essentially prepares you for the exam as well to try to increase our pass rates. We did do some mobile integrated health grants out of that as well. And then also some of our pediatric support systems like HandTevi to help with dosing accuracy and things like that. Some of our big projects with the EMS readiness funding. For certifications, we're up across the board, which is nice, especially at the EMR level. We kind of, our big number is 25,000 overall. We've been trying to get to the 25,000 mark for EMS pre-hospital personnel. We were able to cross that and stay consistently over that for the last calendar year. That is, I think our growth rate overall was about 1.5%. Here we are, that's the, was about 1.5%. This is the breakdown of our workforce. As you can see, a pretty significant amount of ours are at the EMT level, 14,000. We have about 895 advanced level practitioners or providers, and then 5,100 paramedics. And that's another number that we watch pretty closely. 5,000 was kind of a mark that we were looking to go across. That still is, just to be honest, a very severe shortage. That level, we need a lot more paramedics out there. And I think you've heard me say before, when we actually run, how much of that paramedic workforce is out on the street day in, day out, that's relatively low. It's more in the 1,500 to 2,000 range. So still markedly short there.
What is your goal? What is the goal that get us where we need to be?
I think, we need, the problem is our run volume is still increasing at about 2 to 3% a year. So even if we're growing at 1.5, we're losing ground. So, number one, I'd like to see our growth in every certification level outpace our run volume increase. I would like to get our overall responder panel over 30,000, get our paramedic level up to more like 7,500 or ideally 10,000. I think then we're starting to be, and having those ones that are actively, we have a lot, and I love it and I encourage it. I don't mean to minimize it, but a lot that just keep their certs, but actually aren't, working regularly in the field. So.
How's the distribution of your numbers across the state?
That's a great point. That's one of the biggest. It's kind of some of our well-resourced areas are very well supplied with workforce, and some of our rural areas it's spread pretty thin. And then we also get a little bit of false sense of security because in our rural areas, a lot of our providers work for 3 or 4 different services. They'll finish a shift at one place, go over to the next. So when we hear that, a service is 75% staff, sometimes they're 75% staff with all the same people, so that's a challenge as well. So I think,
Is there data that supports, like, we'll just take trauma for an example, that if there's a paramedic that's responding, that you have better outcomes compared to an EMT?
Not in Indiana, but in some places, yes. Now, in the past, it was actually interesting. BLS outperformed ALS in pre-hospital cardiac arrest. With some of the new emphasis on quality uninterrupted CPR, AED registries, and non-interrupting care for procedures, we've seen that flip in the last data I've seen, that ALS has started to outperform again. I don't think I have any Indiana-specific data, but hopefully continue to grow that capability.
So I've been around long enough that there was a time in Ripley County, we did not have paramedics. And then once we got paramedics across the board, things improved.
I mean, personally, for me, I also am thinking about the paramedic engagement and like mobile integrated health and other aspects where we can leverage their training.
I think that's a key point is, number one, we obviously want to grow our workforce, but number two, make sure we're deploying them and, utilizing them appropriately. So the more that we can have them focusing on the higher acuity runs, use MIH to focus on heavy utilizers, readmissions, things like that, that'll make our workforce go farther as well. The other thing, when I mentioned not having Indiana specific data, the statewide CARES report did just come out, I think this week. So I have not had a chance to review that and bring that, but certainly something that we'll do moving forward. So that'll show where Indiana stacks up nationwide and allow you to gauge yourself within Indiana as well. So.
Do you know how many or a proportion of those new EMT certifications move on to advanced training like paramedic training, or is that a goal that is a pathway?
It is, we would love to see, basically the EMT levels kind of dipping your foot and seeing, building that prerequisite knowledge and then saying, okay, I want to go on to advanced. I can't tell you what percent in Indiana move on like that. And that's one of the debates when we talk about the advanced EMT level. Is that is that another, if we would look at the scope of practice at the advanced level, is that another stepping stone to, would that hurt the paramedic levels? Because they say, oh, I'm good at being advanced, or is that a stepping stone to say, now I can do a little more. Let's go on and get that paramedic so I can have the full range. That's a discussion we have with EMS circles as well. This is our historic person, thing. As you can see, we were down, it's just a gradual increase outside of 2021. We've kind of had a steady climb. I think, yeah, there's our total certs. Then as you move, the challenge, there we go. I think this is the key one, we went, and if you go back, we were at like 750,000 in 2018. So if you look at it, I mean, we've gone up, almost 500,000 or more than 500,000 runs in that time frame, with just a small stair step. So, I think that's why we're so focused on this is we're just, even though we're increasing our workforce, we're not necessarily keeping up with that run volume. And so that's, again, when we talk about interfacility transfers, minimizing that volume, trying to get patients to the right place at the right time, all those things to make sure that we're utilizing that precious resource the best we can.
So these are actual runs to hospitals, or does it include where you have to go, but you don't take to a hospital?
I believe that includes non-transport data.
Do you guys have any understanding of why it continued? Is it an aging population? Is it falls? That's I guess, but I don't know.
No, I mean, initially we thought it was just, if you notice 2020 to 2021, we thought it was a pandemic phenomenon that we might trend a little back down to where we were pre-pandemic, but we kind of went up and then just stayed up. So I don't know, there's a lot of things that factor into that, I guess. I think some of it is access, as we look at our rural health transformation stuff, access to care is getting much more challenging. You're seeing folks who are waiting longer for medical conditions that eventually, where it might have been a drive to a primary care physician, all of a sudden is an EMS run to a hospital.
Well, I mean, that data is in there, right? I mean, we should be able to look at that data. And say, what are the levels? Is it increasing that level? I'm thinking of ED coding, but is it a level 5, right? So it's subtoe, or is this like a super critical patient? Like, where are we seeing that? And then is it falls? Like, does the increase in fall runs match with the increase that we're seeing here? So I think that we need to dig into there and see if there's another way of approaching it. I mean, we do know that there's a lot of calls these days for falls, even in long-term care facilities, to have the fire or EMS just help get the person off the floor.
These are our response times. Response times are a challenge. Those are ones that are notoriously inaccurate, but watching, if we measure it the same way, watching that trend is important as well. So response times, they tend to fluctuate, but our nationwide average, the goal is especially for high acuity patients is 7 minutes or less. So we stay pretty close to that. Scene times, we've actually had a lot of discussions at the PI side of things on scene times in our trauma patients, but just in general, we want to make sure as we add things to the EMS scope that we're not disproportionately adding to scene times for things that aren't productive to the overall care continuum there. So our transport times are going up, as you can see, not a ton, but gradually. And again, that's a function of, probably specialty care contraction in some of our rural areas. If you've got somebody with some sort of a stroke or something like that, having to go, instead of 30 minutes, now it's 45, things like that, as we've seen some of our rural hospitals close or contract some of their service delivery lines. A lot of this is more of our EMT level things in our state practical exam data on that side of things. So that's where you can find, we'll email, we're happy to share it with everybody. I don't know if it's in your packets or not, but happy to share that with everyone. And we talked about we have our EMS 2025 initiative. A lot of you were involved in that. Kind of when we became our own division within DHS, we said, let's plan on what that looks like long-term. And so we're talking about some of our funding with that, education, a lot of the same things that I've already covered here, but improving recruitment processes, increasing our pass rate, getting into the high schools earlier to help with our workforce, and then just workforce retention as well. So the other thing that I think is really, really important is creating a more diverse career path for our EMS professionals. I always say a lot of times they say, I'm going to start in EMS and I'm going to lift patients and take care of patients for 20 years till my back goes out and then I retire. There's just not a lot of variance. And so adding alternative career paths, leadership development training, things like that, and opportunities for advancement where they see a little more diverse opportunity tree once they're stable in the field, I think will help with our retention as well. Oh, the last thing on this, we do every other year, we do district forums. So we get out in the state, in each district, do a education day where we kind of do EMS updates, talk about things. So certainly anything from the trauma commission standpoint that you'd like to see included, reach out to me. We'll be discussing, we've talked about adherence to the field triage guidelines. We'll probably have some C-collar discussions and things like that at this, but that's kind of the cadence for the day is, you got to do an update, EMSC's on there. And we have breakout sessions where I'll talk with the medical directors, there's MIH, things like that. So be on the lookout for those in your area.
When you're having those meetings, I would encourage you to remind them about the track resource and also encourage them to please reach out to their local health departments. There's a lot of possibilities, a lot of opportunities with that. And as we roll through the rural health transformation, we got some EMS folks in District 6, but I would just encourage them to be involved and especially moving forward as things roll out.
Absolutely. It is free. No cost to it. That's our schedule there. So how small if your eyes better. We get out all over the state. Anything else from for me on that? Okay, thank you all.
I'm going to review the most recent trauma system planning subcommittee meeting. Okay. Apologize if slides are slightly different from the ones that we started with, so try not to jump around. We started both today and in the trauma system planning meeting with some discussion of the mock, and Brian Bushing has already presented that, so I'm not going to repeat unless anybody has questions. We'll move forward here. There was some discussion about the trauma system funding. And there is general agreement that we need to try to move towards a non-reverting fund. And since 2027 legislature is a budget year, we would like to explore working on that. I presume that would need to be part of the department budget. Best. I mentioned looking at the legislative affairs staff that you have in terms of what language would be needed or opportunities to try to retain those funds year over year, to kind of break this cycle of having to fund short-term projects and so forth. There's also, I think, an openness to additional source of funds other than the department budget. Obviously, the GROW funding is a separate category, but in terms of if we did develop a continuing fund for the trauma system, could there be additional fees, or, traffic fines, or things that could fund that? And that would be a legislative issue that we need to discuss with legislative affairs type of people. Back to the tracks, the Indiana Hospital Association will no longer be serving as the administrator of the funding, and so that's going to be a need for the tracks to take on additional responsibility for managing those funds. Those have been presented already. And there is also an agreement that we should periodically reevaluate the alignment of those funds and the utilization with respect to the system plan. Pause, please interrupt me if there's any questions. In terms of verification activities since the last meeting, there's a list here of some upcoming verifications, including my institution in August. We did also have a longer list of those that have recently been verified or re-verified. Did a remediation to maintain verification, and those are in the meeting minutes. Go to the next. Okay. For designation, we've continued discussion on white space, and I think the Brian Bushing and the trauma that the Department of Health have a little bit more insight into this, but listed here are several hospitals that have been in discussions. I would say as a general concept, there is support from the hospital administrations, but getting provider engagement is more of an issue. And I think that's something that we should work with both the surgeons, emergency medicine providers to try to evaluate and address those issues.
Question from Dr. Bush.
Just to let this group know, some additional folks that were involved with the rural health transformation discussions voiced at least some interest. One is Decatur County in Greensburg. Other is Jennings County Hospital. The other was St. Elizabeth Hospital in Dearborn County. How serious those, but they were just representatives from those organizations did voice interest to that group.
Leading the conversations with these white space hospitals. Who's doing the outreach? Are you doing it?
We generally field the question, loop in the necessary parties from the TCC, and then also follow up with other representatives. I know Ryan's been really helpful when we need more face-to-face conversation from a level 3 that's done it. Really how it goes. I know Andy's active.
Yeah, but it's primary physician. I would say it varies from either surgeons or anesthesia, or there's at least one. It varies from organization to organization as to which group is, I'll say, the biggest barrier. But generally speaking, it's the physician groups are just saying no.
It's the 30-minute response time.
They don't want any more cases.
Yeah, I think some people, the feedback we've gotten is from providers is that they've chosen a smaller practice to have that as a business model or lifestyle. I think part of it is sort of overcoming that a designation may not actually change their volume significantly. That's the feedback we've gotten. So, but it's really more of the kind of trauma readiness. Need to work on that. I think with respect to the white space, you can see these two groups of bullet points are the sort of southeast and then west areas of the state. We're also aware that there's a need to revise the designation standard to reflect the transition to the Trauma Care Commission and be up to date. PRC with respect to verification. Also at the meeting, Dr. Yeazel gave a update on the statewide coordination of free hospital blood. Briefly, he mentioned there are about 15 programs in the state and a similar number in development. And there is a need to coordinate that. Those existing programs are working through, I mean, the name, there's a coalition of pre-hospital blood agencies.
Indiana Free Hospital Blood Coalition. So.
All right.
Creative.
And so that is something that we're working in progress. I think to address Dr. Weaver's question, that, you know, the pre-hospital interventions for trauma have been disappointingly ineffective over the years. That most sort of advanced treatments have not shown tremendous, you know, benefits other than maybe airway interventions. But I think pre-hospital blood is something that people do feel that if you have patients that ultimately need blood, if we can reduce the time needed to get that to them, useful. And this was something where a regional approach may help with some of just the supply and demand issues from the errors in terms of minimizing wastage as those products circulate from being in the field to being in hospitals, so that they slide.
Clicked it. It's not responding.
Well, anyway, the next thing is RFA proposals. We discussed in general terms current and future proposals, and that proposals with a statewide impact should still be evaluated through the appropriate subcommittee, then elevated to the Trauma Care Commission. However, things that are regional could be pulled through the crack, and the system needs to be kind of adapted to allow for that. Some of that is happening organically with some of these like education purchases and stuff, but and again, to be aligned with the trauma system plan. And then finally, there is the RFA proposal that was presented at the TCC meeting in February, which was Dr. Jenkins, sort of phase 2 of the coordination of care improvements that has to do with the designated trauma centers partnering with non-designated centers to do that quality improvement. I'm not going to recapitulate that because that was presented at the last meeting, but the approving the funding is unless there's discussion or question.
Is there discussion, comments, questions? Motion to approve.
Second.
Motion and a second to approve the funding for this RFA proposal quality improvement program. As a reminder, this is IU affiliated, so anybody who needs to abstain, please do so. Weaver, I will abstain. Dr. Hazel,
Abstain.
Dr. Zaire,
Abstain.
Stride,
I'll abstain.
Andy,
Approved.
Dr. Weinstein,
Abstain. Sorry, abstain. Can you hear me?
yeah, we can. Thank you. Kelly Blanton. Fitz,
Same.
Lisa Hollister,
Approved.
Dr. Landman,
Abstain.
Dr. Welsh,
Approve.
Dr. Thomas,
Approved.
Dr. Woodland. It passes. Huh? I know. Okay. All right, so approved to continue with that proposal. Something to consider in the future for the position now. Okay. And then moving on to the Trauma Education and Outreach Subcommittee.
Hey, listen, quick updates, but one for discussion. Old business, just to update our injury prevention mapping. Still struggling a little bit with getting the right resources in place at the state level to help put that together. Not from lack of effort, but still a work in progress to make that come together. Our plans on the project Child Safe actually hit a roadblock on some legal concerns. Again, with just some of the contracting that's gonna have to happen state level. So we're looking at doing that at a more individual hospital level as we're able. But didn't get as far as we wanted to on that one. Social media update, that is actually on track. Just the KPIs that we were put together early on. One of the goals is to increase our instructors by 10. There is a course coming up in June, I believe is what we've settled on now that has,
December, I think, the HLS instructor course.
yeah, is there one in June also, or did it get moved back?
I think it's December.
Okay.
'Cause
Okay.
It's at our facility.
Okay, corrected. There's 8 people going to be at that one then.
I believe so.
Okay.
Which facility? I'm sorry.
St. Vincent Indy.
Okay.
Yeah.
Okay.
I don't think we haven't had people assigned yet.
And I know there's some names being thrown around of who's interested in trying to get that list together. So and that's where I thought they were in June, because that's the dates they were looking at. We'll get together after this. And,
Yeah.
It's a requirement to be an ATLS instructor.
Instructor potential.
yeah, you got to show potential. That's your original. Be marked as potential instructor and attend a course on different ways of teaching and presenting.
The instructor course, like a day and a half.
After an instructor course, you teach as an instructor candidate and
Harder thing is getting an instructor director, like a director for an instructor course. That's difficult. To be a certain level in the COT to be able to do that.
Is your course for new instructors or instructors of instructors?
Instructors of instructors.
Okay. Yeah.
Since we're so business.
The interactive map, we talked about having some IT on that. And the other goal is to create 2 special social media campaigns for injury prevention. We have our scheduled kind of videos that we're going to go out every 2 months. Looking for volunteers though, to have a little more one-on-one personal video from your site, pick a topic, pick a surgeon, ED physician to kind of talk through a scenario or give some special topic. So if you have an interest in that, we could help arrange making that happen.
May or June was injury prevention month.
It doesn't end up having to be for that. We can do it later on. We're just looking to get some more live videos taken care of, more personal.
Are you guys making like a social media like packet that you could just like send to a facility and let them plug and play?
We are not. Our 6 scheduled things are already kind of put together. We're looking for some, we just make it your own type of experience is what we were going to do with it originally.
Okay.
It wasn't going to be a set agenda. You needed to talk your way through, get help with that and give ideas. Want to restrict anybody on what they.
Sometimes just helpful we've done this with local health departments, right? When we're doing whatever pushing, we like kind of send them a package. And so they know like form this little 30-second video, make sure you mention this, but like it helps give them like
Template.
thank you, a template, but like also like fancies it up a little bit and then it will make it consistent across the state. So if whoever from your team, you guys can work with our comms team on that.
So I think there is something going.
Okay, good.
Snag with social positions, but we will
Okay.
be sending something out.
Okay, perfect. And then so if you guys can just know, we'll send it out through the trauma commission and everybody that's on the wider email list but I would love to see, especially at least all of our trauma hospitals take it up and put something out. I think that would be cool. We can do like hashtag trauma care commission.
What does that do again?
We can actually have you at the very end do this.
One-time show. Hey, teenagers, I'm cool.
TikTok.
Is that something we needed to vote on?
We're gonna get to that after the.
Okay.
I will to recognize the folks in Bloomington Hospital, IU Health, they are developing an ATLS program there. And they're set to, I have to do a visit and approve them, but they should be starting ATLS instruction for their emergency medicine residency, which is a new program. I think they have all the infrastructure in place to then go beyond just instruction and want to do instructor courses as well, because they have educators and curriculum center and all the boxes checked for that. be an additional resource in South Central Indiana, I guess.
Are they, what level are they? Trauma center? Alan, thank you.
If the space bar and
Just one slide. You've seen bits and pieces of this in the track reports, but I just wanted to put this together. This is the activity report from 2024 when IHA started doing this work until to April 14th. Some pretty outstanding numbers on how the program has grown. Listed everything down as a combination. 2,177 staff members have been trained in the various programs. With that comes processing of 451 invoices from all of you, with the total amount spent on just on those courses, along with the equipment purchases, under $2 million. The T-CAR, P-CAR, I like to refer to as the 4-letter words. All the people that have been managing this know of the grief. Everybody should have gotten one last report yesterday. I finished those up of the remaining seats. 503 seats we were able to purchase. The costs of the seats were $300 each. We did have some students throughout that expired, so they did not complete their course. One thing that I was able to do by running a weekly report, I was able to catch some of these students before they actually expired, and Vision EM would let me get that seat back. So we actually saved 91 seats. I was able to unwind. So we saved $27,000 that I was able to put back into the seats and give those to more students. So was really happy about that. Threw in some trauma talks, various things in there. The last one was very interesting on facial trauma. I had a couple reports back like, whoa, that was way over my head. But thank you, Dr. Fitz, for sending folks your way. And a total number of participants in both of our symposiums was 674. So when you throw all those people together, 2,851 people have been educated in some form of a trauma program since before when we first started. So anyway, that's just kind of a high level overview of all the things as we look to wrapping up next month. Good job.
Two more quick things. One was we did as a committee to one-time support to the Hoosier Burn, which is starting very soon. Don't look to the year-over-year funding, but they were in places, some things had fallen through, and it was a good opportunity to support them. What we are bringing today, more of the RFA proposal, goes back to the initiative, the trauma simulation program. It originally came through, we reported with 613,000 was the original that is used, and they're asking for some more money for this next year at 518,000. This is what they've done since we started it. The blue ones are completed, a couple of purple are upcoming. Now, AI did not do me great. This is a fair representation, but some of the cities are not exactly where they belong on the map. Once it was noticed, it was too late, so we said it still kind of shows they are doing a good job getting across the state. And they sent an entire packet of what they're doing, the pre and the post testing, and some of the improvements that they're seeing. This is just taking a little blurb taken out of there. I think the primary survey on exsanguination going from 38 to 93. I think the part, there's some initiatives that they are showing good result from on the pre and the post testing. Not all inclusive of everything. This is just a little excerpt of what they had included for us. So we did have from the subcommittee, because this came through after our last meeting, an email discussion. There's some questions asked that seem to have been answered and supported appropriately, but we're bringing this to the entire group here today. Consideration of the 500 details, I do believe are in your packet if you wanted more of them somewhere.
Do you need a motion to approve the additional funding?
If that is desired, yes, that'd be great.
Any comments or questions, or is there a second? The additional funding?
Is there a motion?
She motioned, I think, did you?
Well, I asked about it, but yes, I'll motion to approve.
Oh.
I second.
Second.
The additional funding, Dr. Yeazel? Dr. Zaire?
Yes.
Dr. Stride?
Approve.
Gansey?
Approved.
Dr. Weinstein?
Approved.
Kelly Blanton?
Approved.
Dr. Fitz?
Approved.
Lisa Hollister?
Approved.
Dr. Landman?
Approved.
Dr. Welsh?
Approved.
Dr. Thomas?
Approved.
Dr. Woodson?
Approved.
Okay. It is approved. Thank you. Okay, registry subcommittee, Lisa?
So looking over the first 3, we have that data and those reports are probably out on some. The trauma volume continues to increase just a little bit each year. And I wanted to point out that greater than 50% of the patients are over 65, 36% are over 75, and 1 in every 6 patients. I mean, that's pretty shocking. That's why when I look at the runs and I think about, I have a neighbor who calls us every day to pick her husband up. Go to the hospital. So I think a lot of runs are related to falls. So our system is predominantly geriatric. So the under triage still exists. This is not a problem that's going away. So a substantial proportion of our high risk red patients are going to non-trauma centers. It's relatively stable, but it's persistent system behavior. It's not rare. And it's really a problem throughout the state. In the north, we are creating an awareness campaign of the triage and transport, which is 45 minutes. Everybody is touching on that. Maybe why this happens is because of geriatric patients. So if we look at patients that are over 75, their injuries are less obvious. They have more comorbidities and it's more difficult to recognize their severity. So triage is more complex in these patients. And some people don't, even how much they're from bone fractures and the extent of their injuries. So it's, is this the problem? Is it because of the geriatric? I don't know. One of my asks, which is not on these slides, and this is kind of a PI committee thing up in our North Track, is to be able to get down into the case level, the patient data, looking at each case. We can't do that right now as the state. So whatever we could do legally, whoever could move that forward. Nicole is kind of helping us to try to do that. We have to get down into each case and try to figure out the real reason why patients aren't going to trauma centers. Is it because they're too far away? I don't think that's it, because we are seeing it even in out. It's going to trauma centers. So legally, how can we dig into the cases? And potentially up in North Track, we would kind of like to do maybe a fatality review team. So transfer reality, we've talked about this for all the time, the less than 2 hours, the majority of the patients exceed the benchmark, but I really think it's a problem of patients going to non-trauma centers, and it's really hard to stabilize these patients, coordinate the care, and then transport limitations. So if they could get to the right hospital to start with, you wouldn't have this problem. So time reflects the complexity, probably not simply just the delay. Looking forward, the demand is increasing, the volume is ticking up, the population is aging, the patterns are stable, but really the opportunity is in earlier alignment, not just the faster movement after they get to a non-trauma center. Dr. Thomas already said this about Parkview. level 1 in 2026. The next meeting is July 1st. Also, the registry subcommittee is creating a subcommittee, which should just be registrars. No one else but registrars to talk about registrar things and data collection and data accuracy and validation and all of those things. So that's all I've got. That was already mentioned. And I wanted Brian to add a picture of my car this morning because I got a new Hoosier black plate that says no alarm. No more getting up early.
That's funny.
Go back to the registry, So if we had a level 4, like the other states have, all the hospitals would be considered trauma hospitals. So is there a different way to look at the registry for appropriate level of care that like this needed to go to a level 3 or this needed to go to a level 2 or 1 type of care?
And what we're talking about here, we're only looking at red patients,
Just
just red. So all the patients in the red shouldn't go to a 3 or a 4. They should only go to a higher, really, they should only go to once. If you have a 1. Up in the north, we don't have one. So red patients should be triaged to the highest. That makes sense. Is that answering the question?
That does. I know just, that's always been the pushback for non-trauma hospitals is that, okay, these are just falls or these just, but if we're just focusing on red, that makes more sense.
But the reds can be just falls. Because they can bleed and they can have a low blood pressure and
You think when I think anecdotally, at least, our 65 and up population is much more likely to have a strong destination preference themselves. So some of that may be patient induced where they're like, I always go to this place and I'm not going anywhere else. And my, 9-year-old husband or wife isn't
my
going
dad,
to.
he didn't come to my hospital because he was born at the other hospital.
Yeah, exactly.
You were born there.
Now, on the flip side, I think it's our job in EMS to provide not just do a half-ass like, well, sounds good, we'll take you there, but to do appropriate, this is why I'm recommending that for reasons A, B, and C.
And educating.
There's a couple different kinds of, some people make a good faith effort to destination guidance, some just say, okay, sounds good, and really focusing with our EMS professionals on education when that is a preference,
I think that is an issue that obviously can be addressed with the mock development in terms of the statewide system that, if you have a pre-hospital triage trigger that determines the destination, that's something that can be made to happen. Alabama is an example of that. I'm happy to connect set up a pre-config to their system. Reflecting back on your data from earlier, Dr. Yeazel, like your average transport time in the state is 15 minutes. So that I think also tells us that patients are not being transported. They are being transported to the closest facility, not necessarily the trauma center. So I think that some of those times might be longer, although maybe that's all transports and not trauma. So
I think we're also weighted a little bit by just in Indianapolis, so many short, Fort Wayne, within the city, there's a lot of short transport times. So it's heavily weighted towards that. So I do think in our areas, we do get some outliers with much longer times too. So it's kind of hard to parse out where the problem spots.
The state population went up.
Slowly, yeah, we're going up, yeah. And just, Indy and the donut counties are 1/6 of the whole state, right? And so again, to go back to the EMS data, we can't just look at that like upfront, like separate it, right? Like let's look at rural counties, take out the donut counties, and then what are we from a transport time?
Outside of the donut county, those are the ones that are ones. I think there's maybe 2 or 3 other counties that had a positive population thing, but most of it was Marion County and the surrounding. I think there were a couple others, but that's where
From a population standpoint. Yeah, but our transport times are much longer in our rural. Right, Dr. Yeazel.
the performance improvement subcommittee, Dr. Thomas and myself, chaired it. We had, I think, probably our best meeting. We had some really great discussions that nothing concrete to bring here, but a lot of positive discussions. We still have down on 3 KPIs mainly to focus on, kind of in line with the discussion we just had, over and under triage and utilization of patients in trauma centers, making sure that we're taking the right patient to the right place at the right time. Again, we talk about how feedback for our providers that are doing the transferring, am I sending this condition to a trauma center every time and they're discharged an hour later? The facial fracture discussion is a big one. That's been a focus. There's a lot of high transfer rates with not a lot of utility at the destination. A lot of them are discharged rapidly. Looking at our scene times, I've heard that from several parts of the state that there's some prolonged scene times with our trauma patients. Again, that is outside of the extrication process, planning on the scene to do assessments and things like that. So really looking at that and seeing if there's variance throughout the state and maybe some targeted areas to do some outreach. Looking at number of and outcomes for our pediatric ready facility. So we want to continue to grow the pediatric readiness and then demonstrate its effectiveness with outcomes data as well. So those are 3 that we're really focused on. That's some other things we talked about and we brought up a few times here. ACS field triage guideline adherence. When it first came out, we did a campaign. Felt like we got some education out there, but I think kind of seen some gradual backslide from that. So just kind of to reinforce that, again, in line with what we've talked about. And then just the structure. We talked about, what our role is at the commission level PI versus looking at the tracks and their PI processes as well. And kind of that bi-directional flow, like how does the South track bring an issue to us that they think we should look at it more at the macro level? How do we take the initiatives that we've looked at and said, okay, this part of the state's an outlier. How do we, bring that back to the tracks as well? So we did come up with a recommendation that all 3 tracks have PI committees. I know North at least has one or is putting one together, I believe. I don't know where Central and South is on that, but certainly something I think would be beneficial to the process, and just having that communication point that could go back to our track meetings and say, these are some of the PI focuses that we have as well. Nothing for vote, and next meeting, I think that's wrong. I think it's in August. So hold that on the next meeting date, is it? It's wrong. I think that's the wrong date. So hold that on, and I'll get the next meeting out to everybody.
Your performance improvement, any look at the vehicle capacity in the rural counties? That was something that came up with another group where some of the rural counties only have a couple of vehicles, EMS.
Oh, I see.
Available.
Within the vehicle, I was like,
I know.
Yeah, we do especially a lot of our southern counties are what I call 2-unit counties, where they're covered, wide geographical area from low populations that are covered by 2 units. So essentially anytime they're out of county, real fast and long, turnaround times if they do go to trauma facilities and things like that. So, are we cognizant of it? Yes. Do I know offhand how to, parse that out and see, that's a little bit more of a challenge.
I'm going to talk to you after we're done. I got some that's come up.
Absolutely. The other thing is when you have 2 or 3 counties that are 2-unit counties adjacent to each other, they all say, oh, we have mutual aid with this county. How effective is that mutual aid? They're running thin day in, day out too. So if you're counting on them to backfill you, they have their own challenges. So.
Need to use the keyboard.
Okay.
So, we have been busy in our National Preparedness Military Integration Subcommittee. You're continuing to roll out the previous vote on the statewide TAA. Just want to big shout out to Lieutenant Colonel Stelanos for hard work, along with Dr. Wow. They're spearheading that effort. APIs have not changed, just to make sure folks are aware. There's some activities that are going to be coming up in the coming months. Terre Haute area's got a program coming up sure the exact dates. This summer in July, the Urban Search and Rescue of Piscatatuck will be held again. I believe that one in Terre Haute's going to be have folks from IDF as some of the instructors, as well as the one at Urban Search and Rescue. Still working on the project for a mass casualty tabletop and for a statewide burn activity to see how we would respond as the limited resources and transportation time. I actually wanted to take the bulk of the time I had to let you know about a fantastic presentation we had with Mr. Hicks from the Administration for Strategic Preparedness and Response. Slides from his talk are in your packet. I would encourage you to look through it. I think it covers a number of things that we've talked about and looks for a number of opportunities. I'm not going to go through each one, but just want to highlight a few things. One, some of the core function areas that the group deals with is patient evacuation, which we've talked about, especially where county EMS, whether there's a bad disaster, how do you get folks to the right location? Deals with public health and medical information, blood and blood products, how do you get it? We were talking earlier about the pre-hospital transfusion and vector control, which being a rural health officer, that's close to my heart. One of the things that caught my eye, the National Disaster Medical System has to do with patient movement, what we've talked about before. Things that he brought up had to do with patient identification and the system. That's something I think that can help us. His group deals with federal patient movement, planes, trains, and automobiles, pickup trucks if you're in a rural setting. But this all goes through his office, and I think page 11 talks about federal patient movement tracking and how they keep track of the folks when they're involved. And, you know, maybe there's an opportunity that we can learn when we talked about how do we track the trauma patient EMS to the outlying hospital to the trauma center, and how do we look at that case? Can we do better? Right now, that's multiple different identifying numbers, and how do you do the research on that? And you know that his group may be able to give us some insight of some opportunities. But I would get back to the other one that we talked about is beds. When it comes to trauma and natural disasters, and he also talked about his group deals with a number of facilities, and they have a way of tracking available beds. That may be something that we can piggyback onto, especially if we have an uber big disaster. And his contact, Mr. Hicks' contact information is theirs. He was very open to discussion and communication. I think I saw opportunities here. This is a really good presentation. If the group is looking for some additional education and we have time on the agenda, this might be something that this group would appreciate because it covers a lot of things that a lot of challenges that we deal with meeting after meeting. I don't think it's the answer for everything, but they give us some insight or some ideas to what can we get to work for our system. Any questions? And Mr. Hicks was one of the better presenters. Some of these folks, they can be a little dry with the federal government, but he actually was very, very entertaining. And had the room on the edge of their seat. The other staff that was there, I think they can concur that it was, we kind of ran out of time. We could have listened to him, just get some ideas off him much longer. Yes, sir.
I mean, I interpret your slides as like, this is a federal mock that he's describing. Just sort of, and I know the military is involved with the COT discussions on mock, but right. I mean, is your sense that these are two public mocks that we're all talking about, and then the federal mock, are these like two silos that are being created separately and not talking? It just seems like there's two systems being set up And especially when we're talking about LISCOs that would be managed by the federal government, these large scale operations, it would.
So I think it's one of those things where we got different groups working on some similar challenges.
Right.
Things that I've liked about state and Department of Health is thinking outside the box, being innovative. It's like, because the statewide TA, for instance, it hadn't been done before. You know, so just because it has been done before, you know, that doesn't hold this group back. You know, I think there may be parts of this that we can look to see, is it an opportunity for us that they're identifying number, track patients once their system is activated. That's something that we can do a version of that for trauma patients. You know, I think there's, and transporting, knowing what's available bed-wise across the state. That he knows with the facilities that his group covers. You know, what's involved with that, is that applicable to trauma beds or trauma beds and rehab beds? And, you know, just, there's a lot here I think that can help us. Can we duplicate it? I don't think so, but food for thought, maybe tear down a silo or two, and that's never bother taking somebody else's good idea and see if it can help us.
The NDMS actually has been working with the COT, yeah, and you're right, they were siloed. They really weren't very functional prior to all this discussion of LISCO, and finally getting rebooted. And it looks like that they're definitely integrating. I don't know if you were in on that talk, you know, the 8 different RMOC talks that we had with the COT, but NDMS came and discussed it, and just getting off the ground again to understand how they can work with everybody without that of you do your own thing.
It seems like a perfect storm for
Yeah.
siloed care and paramedic.
Are they already talking to states or no?
I would say indirectly, they're talking to states, it's promulgating now, but it's not really mature. So, we heard a very good presentation from them probably 3 months ago. But they have a lot of work. You know, repatriation, if we got into anything bad, is not set up. Where are we gonna send these folks? I think they understand that they cannot work by themselves, that they need to work with a multitude of groups to make this happen. And the COT's been sort of at the forefront of the RMOC, so that's why they were tied in the COT. So.
Do you have any Hoosiers that are engaged in this conversation to make sure that we're progress?
Dr. Strive and I are in that arena right now. So it's tied in with the RMOC discussions.
That's what I'm saying, like, as we're building our mock, I mean, rather than like, be like, oh, there's this other thing that we may need to coordinate with, I would like to build it together.
Yeah, there's definitely a concept that a regional or a statewide mock would be a piece of that would to interact with adjacent, like the Ohio mock or the Michigan one or whatever, in a way that then become pieces of a national trauma and emergency preparedness system. So NTEPS is one concept that's talked about a lot. And yeah, there are some silos and a certain amount of overlapping, and it's hard to make like a Venn diagram that there's all of these things, but some of it has to do with these different programs have different funding sources, I think. And so that's why they're somewhat separate. There's definitely need for some integration of those things when it comes to the RMOCs that we're talking about with the NDMS disasters, and then the military civilian training integration issues are often also discussed in the same arena. Programs that can help maintain both military and civilian preparedness.
And they're involved in setting up currently 15 RMOCs in the country to start off. Indiana was not one of those, which is why we're glad we're doing what we're doing. But as I see it, that'll really take off once they get that first 15 up and running. It's going to take a bit of time. But it's the same concept as what we're trying to do in Indiana, right? We want to get healthcare coalitions involved with our discussions with RMOCs. And I know that they don't want to be siloed. We don't want to be siloed. We need to be together. The NDMS, I think for the first time ever, is really engaging on that kind of a platform. Hopefully more to come. And we can keep you posted as we hear.
Please do, because I can just imagine too, this might be help with sustainability of our mock too, right? Because eventually, if the federal government really supports this idea and wants to be prepared, and there will be funding tied to it to the states that are ready to do it. So I want to make sure that we say these are at the top of their mind for the next state to bring on.
As far as I know, we're unique in using the rural health funding at this development. However, that is also, I think, other people are aware that this is an interesting pilot to use that versus DMS or military funding or, whatever. So I think that we should proceed with what we're doing and have an eye on the future of where the system is going.
At the conference I was at this week, they polled all the states that were there, and it seemed very either or. Like some were like, "Why are you doing an RMOC? That's what NDMS is." And some other places like, "We've never heard of that. That's why we're doing the RMOC." So I do think you're getting some of that siloing already. So I think it's an excellent point that as we build, probably need to reach out to whoever would be covering Indiana and make sure we're doing that locksteps.
That if you look at the history of responses, whether that be health or military or whatever, when you are practicing it on a lower level every day, you are much more successful when it's game time. So I am proud of the direction we're going because we're going to use this functioning model data it's needed and hopefully never during, but if it is, we'll be ready.
And I agree with that. I just wanted to point out one of your slides showed Chris Heck. He's the operations lead for NDMS, and he gave a presentation. He worked at Memorial Hospital of South Bend, so we have a tie-in with him. So we do have an in with that. Indiana is absolutely unique with what we have done, push forward with the RMOC concept with our monies, and we are being watched as a pilot project nationally.
Successful pilot project. Hashtag trauma care commission.
There's a lot of
No pressure.
a lot of positive,
It was nice.
a lot of encouragement. But all
Dr. Welsh. That does end our agenda for the day. Any final business, any other comments, questions? Yes, please do your readiness assessment. We need this done ASAP by the end of May. Yes, as always, since you've done it. So yes, go ahead.
Can I add to the readiness assessment? Is that okay?
Go ahead, Dr. Weinstein.
Hi, hello. Sorry that I'm talking to you from afar, but and I know that there was a plug made while I was trying to get on earlier, but right now we have a number of hospitals that have not completed the readiness assessment. Previously, we've had really good engagement with this, and those numbers have helped us really move the needle on what our hospitals are able to do in terms of caring for kids, and it has also supported what we anticipate as funding through GROW to continue to enhance that. But we need hospitals to participate. This includes a lot of hospitals in all of our tracks. And so anything you can do to encourage the hospitals that you're working with or work for on a regular basis to participate would be really helpful. And if they have questions, they're not filling it out because they ran into a question, they're like, I don't know how to answer that. I don't know how to find that information. Please just have them reach out to Margot or me or Lindsay. We're happy to help people walk through the assessment. But getting it done is really important and will help us continue to do good work. That's it. Thank you.
I'm wondering too, if you guys could share them on your regional. The hospital participation on there. Right?
Yes. It depends on if it's the right spit. There are some CEOs in that. Usually Sal through channels.
We'll work on it together. I think I might add, it is time to start thinking about legislative session, 2027, which is a budget year. I will add that if we're looking to move to non-reverting funding, that is an exposure point. And so we'll need to come with very clear how we've used the funding, where have the improvements been, all of the numbers of the people trained and advancements, everything. I mean, it's going to have to be packaged really well. Probably be ready to start talking to legislators come the fall. I would add, I like the idea of including the ability to do a more morbidity and mortality review, leveraging the language that we already have for suicide, overdose, and maternal mortality review, where they are allowed to dig into charts we already have legislative language. We have just updated it for trauma. I guess I'm just making the recommendation, like it should be packaged together. We will see from the Department of Health standpoint, but that does not prohibit any of you from. It is time to start thinking about it. Next questions? All right, we are, yes.
EMS week in a couple of weeks. Thank you, your EMS providers.
Thank you guys